Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with the director of the Yale Cancer Center, Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation with Dr. Siba Haykal. Dr. Haykal is Section Chief of Reconstructive Oncology for the Division of Plastic Reconstructive Surgery in the Department of Surgery at the Yale School of Medicine. Here's Dr. Weiner.
Tonight, we're going to be learning about progress made in the field of breast reconstruction surgery. And I have to say that when I was starting my career as a medical oncologist focused on breast cancer, it was the minority of women who had breast reconstruction. And it was not necessarily such an easy procedure back then, and we're talking about 30 years ago. But things have changed a lot. So we're going to be talking about reconstruction. We're going to be talking about the best approaches to treat lymphedema, which can be caused by the surgery itself and occasionally caused by cancer. Let's talk about breast reconstruction. And I think that for our listeners, it would probably be useful to talk about when a woman considers reconstruction, and we can talk about the different types of reconstruction that are available. And I think that we should really, for the moment, focus on reconstruction that occurs in a woman who's either had cancer or perhaps in a woman who has a genetic predisposition to cancer and chooses to have her breasts removed to help prevent cancer. So we're not just talking about a cosmetic procedure. We're talking about a procedure that's done because there's a need to do a mastectomy. So first, actually, why don't we start with the patients who have a BRCA1 or BRCA2 mutation, where a woman is at very high risk of developing breast cancer and who may decide that rather than continue to have that high risk, that she wants to have her breast removed. What are the options for reconstruction in that setting? Yeah,
I think that's a very important question. And definitely I see a lot of women who are at high risk. And importantly, they either found out they were at high risk because they were genetically tested or they had family members who had breast cancer, and that therefore led to genetic testing. So in those instances where there's a genetic risk factor, then typically a breast surgeon will discuss mastectomies and bilateral mastectomies with these patients. And the options that are available are divided into two folds. So typically we can either use tissue expanders or implant-based reconstruction. And the other option is to use someone's own tissues. And how do we make that decision? Well, it depends on many things. It depends on patients' risk factors, their medical comorbidities, whether or not they have certain available what we call donor sites, so areas where we can actually take the tissue from if they choose to have their own breast tissue. But a lot of things also depend on the patient's age and the long-term outcomes of breast reconstruction. And I'm happy to go into details about those options.
And we can save some of that for the woman who's had breast cancer. You know, in most of these women who are choosing to have their breasts removed because of a gene mutation, we're often talking about somewhat younger women because the data to support performing bilateral mastectomies as a preventive measure get weaker as a woman gets older.
Absolutely.
And really the greatest benefit is probably in the youngest patients.
Definitely.
And I suppose that in somebody who has not had cancer, the the surgical approach is a little bit easier in some sense because you don't have to worry about doing a cancer operation at the same time.
I mean, I would say we kind of treat it the same way, but we do. I think it's important because our goal is to, from a breast cancer and breast surgery perspective, our goal is to make sure that there is no chance that they will have breast cancer, right? So basically, the plan will be to remove all breast tissue. Obviously, certain things that we do tend to think about possibly keeping are the nipple areolar complex, which in some women who do have cancer, we also can keep that as well. So I don't think that our management from a surgical perspective actually changes. And from a reconstruction perspective, what does change are things like patient age, because we know that there are some options that they tell us, for example, that the shelf life of an implant is about 10 to 15 years. So we expect that if a younger woman has a breast implants put in, that we would expect some kind of revision in their future. The other thing to consider is whether or not they've had any pregnancies, or if they've had, children, or want to anticipate fertility and pregnancy. And in that case, we think about whether or not the abdomen should be used as possibly a donor site to make a breast. So those are the things that we consider. But in terms of the surgical options, it doesn't really change what we would do surgically. I mean, our incisions might differ potentially.
Yeah. And I guess the one difference, and this is less for you and more for the breast surgeon, would be that in patients where there is not thought to be cancer, there isn't a need to do a sentinel biopsy. Correct. Or any kind of axillary evaluation. So,
and also maybe radiation. Definitely radiation would not be required. Clearly. And therefore, we have more options as plastic surgeons what we can offer our patients.
We're going to get to the radiation issue in a few minutes. And so for the person who has cancer, I guess the options are relatively similar in the sense that you can talk about a tissue expander and an implant. You can talk about an autologous reconstruction. And maybe you can just tell us a little bit about these autologous reconstructions, because on the one hand, I think a lot of people think they provide the most long-lasting and natural-appearing breast reconstruction. On the other hand, it is a bigger surgery.
Definitely. So the autologous options range. So we can take them from the abdomen, the belly. So that's called a deep flap. We can take some fat, skin, and tissue from the buttocks. That's called an S-gap. We can take them from the medial thigh. That's called a tug flap. We can take them from the posterior thigh. That's called a pap flap. Or from the back. That's called, from the lower back. That's called the lap flap. And then there's some other options in combination with expanders and implant. So those techniques are important because it's a better option for long-lasting result. It's a better option for natural-looking breasts and a natural feel. But what they involve actually disconnecting the skin, the fat, and the tissue, and basing them off of small little blood vessels that actually give them that blood supply. So you actually have to disconnect them from those areas and reconnect them in vessels that are typically located underneath a small piece of a rib. So we're talking about putting together 2 to 3 millimeter vessels.
So is this microsurgery?
Yes. So this is exactly that. So we use loops to actually procure the tissue, so to get those flaps. And we use a microscope. And recently now we're also using a robot to put together these vessels. So this is called microsurgery. And it involves us putting together both an artery and a vein.
And is that why it takes so long?
Yes.
Because you're talking about very technical, very fine surgery, which I can only imagine each vessel that you reconnect takes a certain amount of time?
Yeah. So, interestingly now, we do spend a lot of time on also shaping the breast. So although part of it could take about 1 to 2 hours to actually procure the flap, depending on the location, one flap. If you're doing 2 sides, that's going to take almost double. But what's also important is that we do spend a lot of time in shaping them. So making sure that connection is working okay, making sure we put the tissue in a particular position to really look at areas that potentially our patient wants restored and enhanced. And I think there are many microsurgeons who do this procedure, but I think the really good ones are the ones who really focus on the shape and to restore that appearance so that our patients are actually happy with the way they look at the end of surgery. And I think that's a very intricate part of that procedure.
And the length of these procedures, so if you're doing a bilateral procedure, this is
about 8 hours.
Wow.
Yeah.
That's a while. It's a while for the patient. It's actually a long time for you standing up there as well.
Yeah, but it's honestly what I love doing the most. I can't imagine doing anything else.
Wow. Okay. That's it's really interesting. And then there is some new technique that you've been using as well. And this is the robotic technique that you mentioned briefly before. How does that change things?
Yes. So we just acquired the Simani robot. So the Simani robot, it basically allows us to put together the vessels that are, 2 millimeters in size. And it allows us to do that with better precision. So instead of being under the microscope, we're sitting potentially at a console, so a little bit off the table, and allows us to bring these vessels together with finer instruments and to make it safer and more precise to do.
Wow. Well, we're going to take just a break for a minute, but when we come back, we'll talk a little more about reconstruction. We'll also talk about the complicated issue of radiation in reconstruction, which I think is important for people to hear. And then we'll move on and talk about lymphedema. So we'll just be back in a minute.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where researchers, as part of the Yale Spore and Skin Cancer, work to improve prevention and therapies for patients with melanoma. SmiloCancerHospital.org. The American Cancer Society estimates that over 200,000 cases of melanoma will be diagnosed in the United States this year, with over 1,000 patients in Connecticut alone. While melanoma accounts for only about 1% of skin cancer cases, it causes the most skin cancer deaths. But when detected early, it is easily treated and highly curable. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilow Cancer Hospital, to test innovative new treatments for melanoma. The goal of the Specialized Programs of Research Excellence in Skin Cancer grant is to better understand the biology of skin cancer with a focus on discovering targets that will lead to improved diagnosis and treatment. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Hello again. This is Eric Weiner at Yale Cancer Answers. I'm the director of the Yale Cancer Center, and today we have a special guest, Dr. Siba Haykal, who is a breast reconstruction surgeon. And we're talking about breast reconstruction after cancer. And then we're going to be moving on and talking a bit about lymphedema. So let's just finish up this discussion about reconstruction. So first, could you talk about the complications that sometimes arise or the complicated nature of decision-making when we're giving radiation for the treatment of breast cancer in a woman who's had a mastectomy and also wants reconstruction?
So the issue of radiation, I think, is something that we bring up and talk a lot about while we're having the conversation about breast reconstruction. So I think the important things to really know, essentially it comes down to radiation and implants don't necessarily do well. So what that means is that the long-lasting results of an implant, if a patient is having radiation, are not ideal. And why is that? So the body sees an implant as a foreign body. So it will basically wall it off. And that naturally happens. That happens in all cases, even in the context of breast augmentation, for example, for cosmetic reasons. However, there are some instances where that capsule that forms can get hard, can get tight, can distort the implant, and can make it very painful. So that can happen in about 7 to 10% of all cases. However, if radiation is given, that tendency can actually happen in about 30 to even 40% of cases. So typically, when someone has either had radiation, they're not a good candidate for expansion because you can't expand radiated tissue. Ideally, what you want to do is use their own tissue, whether that's tissue from the belly, whether that's tissue from the back in conjunction with implants and expanders. So we talk about that a lot. Now, if they haven't had radiation, then, ideally we would, and they definitely want implant-based reconstruction, or maybe they're only a candidate for that, we would put a tissue expander in, expand it, radiate the expander, and then go back at a later time, wait at least 6 months, take the expander out, and put an implant in. But despite that, the radiation can still have an effect on the implants. Absolutely.
And I think this is one of the reasons why, if we absolutely know that someone is going to need radiation, whether they have a lumpectomy or whether they have a mastectomy, that if a woman can get by with having a lumpectomy, then if you know that radiation is going to be given, sometimes that's a real push to do that lesser surgical procedure.
Yeah, and interestingly, I think something that where plastic surgeons are also involved is they're involved in that lumpectomy. They can be involved by rearranging the tissue, especially in larger breasts, because you can rearrange the tissue, close up the area, the cavity, and also maybe reduce the other side. And then what's interesting about that is that not only is it a more aesthetic procedure, but even the effect of radiation on that smaller breast volume is actually more important long term.
I'm actually glad you brought that up, because I was going to ask you about the role of reconstruction on at least an occasional basis in the woman who has less than a mastectomy. All right. And last question regarding reconstruction. What about the nipple? Can you reconstruct a nipple, and how do you do that?
Yeah. So there are certain instances where we can keep the nipple areola, but if the nipple areola has to be removed for either a cancer because the cancer is close, or the nipple areola is not in the right location and needs to be removed. So there are two ways that we can actually do the nipple areola reconstruction. One way is to actually bunch up some tissue, kind of like origami, and to create a small little elevation that looks like a nipple. This is not a normal nipple. It's not a nipple that has sensation or changes whether it's hot or cold. And then later what we can do is tattoo the nipple and tattoo the areola. Another way to do it is to actually do a 3D tattoo. So it looks like there's an elevation where the nipple is actually located, but it's almost like an illusion. But the whole thing is tattooed.
Got it. And finally, are there surveys that have been done that get at how satisfied women are with breast reconstruction and with different types of reconstruction?
Absolutely. It's more than surveys. It's like years and years of studies looking at patient-reported outcomes. we definitely know that, from all of that is that women who undergo breast reconstruction do better from a psychological perspective, but also do better from a quality of life perspective. And then generally they're more satisfied. That applies for patients who have breast cancer at all stages, even stage 4 disease. So we know that they do quite well. And that immediate reconstruction, so at the time of mastectomy, even leads to a higher psychological effect and better quality of life than delayed reconstruction, which is reconstruction at any time after mastectomy, where women actually have to live with no breasts or a scar, etc.
And just to say it, there are patients occasionally, maybe a little more often, who are perfectly happy not having breasts.
Absolutely.
And who will say, and I'm reminded of someone years ago who said to me, I just want to have my breasts removed and be flat chested, and it's totally fine. So I think this like many areas in medicine, many areas in cancer medicine is a situation where we listen very carefully to the patient.
Absolutely. An area where we actually get involved as well is something called aesthetic flat closure. And that's where the plastic surgeon is also involved in making sure that the incisions are nice and flat for women who choose not to have breast reconstruction. So we can remove a lot of redundant skin, redundant tissue, so that they can actually look better flat without any breast mound at all. So we're also involved in that. And if anything, I do that fairly commonly.
Okay. So let's move on and talk about something else that is oftentimes very distressing for patients, and that is lymphedema, typically swelling of the arm, although lymphedema can also mean swelling of the breast itself. And what has struck me over the years as a clinician is that even very small amounts of lymphedema that to my eye looks very, very minor, can oftentimes be very distressing to a woman. That it's both uncomfortable and I think oftentimes people are even more distressed by the discomfort than by any appearance. And maybe you could talk a little bit about lymphedema, and then we'll get into how we potentially can prevent it.
Absolutely. So as you mentioned, lymphedema is chronic swelling, so swelling that doesn't go away. And it has many stages. It initially starts out as what we call stage 0, meaning that you actually cannot see the difference in terms of change in volume or swelling, but patients feel discomfort. And those are important to follow and listen. And this is why it's important to continue to have those conversations with our patients, because you don't see any changes. There are no skin changes at all. There's no increase in volume, but they're feeling that discomfort. So I think it's important to monitor them and do specific tests to look at whether or not there's any changes that we can't see. Eventually, what happens with lymphedema is that you can go chronic swelling happens. The swelling does not go away. It ranges from what we call pitting edema, meaning you can compress it, you can mobilize it, you can use a lot of wraps to try to prevent it and help it. But eventually it leads to skin changes that are irreversible, that we cannot reduce that volume at all.
Yeah, it can be highly, highly variable. And I just want to say for our listeners that our colleagues in breast surgery have made really very significant strides over the past 10 to 20 years, reducing the extent of surgery to the axilla, to the armpit, which is typically the most common cause of lymphedema, although radiation in that area can also cause it. So what can we potentially do about lymphedema if we know in particular that someone's going to be at high risk?
Yeah. So I think it's important to recognize who are going to be the people who are going to be at high risk, right? So you mentioned radiation. Chemotherapy is actually also considered a risk factor. Things like diabetes, a BMI of over 30, and some autoimmune diseases are actually considered risk factors for lymphedema. And we particularly looked at a group of about 16,000 patients who've had axillary lymph node dissection and whether or not they develop lymphedema. And we looked at, can we put together a predictive tool to see who's more at risk? So once we know we've identified that someone is at risk, this is a multidisciplinary group, right? We have to make sure that they have someone that they can see, such a physiotherapist or an occupational therapist that is involved in wrapping. The treatment of lymphedema centers around what we call combined decongestive therapy. So that means manual lymphatic drainage and compression and massaging. So we have to really identify that initially.
And that's really quite a commitment on a patient's part. I mean, it can take time, and it involves oftentimes wearing a sleeve or bandages, and it's significant. What about lymphatic reconstruction? I think that's something you've been involved in over the recent years, or maybe longer.
Yeah, I've been involved in this for probably about 7 years. Where in the patients who, depending on their stage of lymphedema, we can offer them some physiologic techniques. So what does that mean? So our goal is to restore lymphatic flow. So one way that we can do this is do specific type of imaging, identify those lymphatic vessels. Those lymphatic vessels are less than 1 millimeter in size. They range between 0.2 millimeters to 1 millimeters. Find those lymphatics and reroute them into a vein, for example, in order for the vein to pick up that lymphatic flow. That's called a lymphovenous bypass. Another way to do this is to transplant lymph nodes from one part of the body to the other. That's called a vascularized lymph node transplantation. And other options are things like liposuction.
Those approaches presumably can help in at least in some patients.
Absolutely. So for the lymphovenous bypasses, we think that it decreases their volume by about 30%. And then in later stages, we think that the vascularized lymph node transplantation actually can generate some factors that will promote new lymphatic vessels to form.
Got it. And is the imaging that you use lymphangiography? So
one technique is a lymphoscintigraphy. The other technique is an MRI lymphangiography, which we have some great expert radiologists here that can look at that. And another very important one is called an ICG lymphangiography, which is an injection of a fluorescent dye called indocyanine green that allows us to really visualize any working lymphatics to be able to bypass them.
Dr. Siba Haykal is Section Chief of Reconstructive Oncology for the Division of Plastic and Reconstructive Surgery in the Department of Surgery at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.